Welcome to this video entitled Viral Hepatitis. We will begin by looking at a few key concepts. 1. Hepatitis A is transmitted via the fecal-oral route. Conditions in which transmission is more likely to occur include travel to countries with high rates of hepatitis A, poor conditions and hygiene, and overcrowded areas. 2. Hepatitis A causes an acute illness and does not lead to chronic liver disease. The infection can be divided into 3 stages, namely, incubation, acute hepatitis, and convalescence. The disease is typically self-limited and rarely progresses to liver failure. 3. Treatment of acute hepatitis A infection is primarily supportive, as pharmacologic treatment with antiviral agents is of no benefit. 4. Hepatitis B virus can cause both an acute and chronic illness and is more difficult to clear if acquired as an infant compared to acquisition as an adult. 5. The choice of first-line therapy for hepatitis B virus when comparing interferon alpha-2b and lamivudine is controversial. The duration of interferon alpha-2b therapy is finite, lasting 16 to 52 weeks relative to lamivudine, which lasts 52 weeks or longer for chronic hepatitis B, but is associated with significant side effects. 6. Long-term therapy with lamivudine is associated with the development of hepatitis B virus strains that are resistant to this agent. Although the impact of developing lamivudine-resistant hepatitis B virus is not known, adafovir may be used to treat these resistant strains. 7. All infants should be immunized against hepatitis B. Older children and adults in high-risk groups who have not been previously immunized should also receive the vaccine. 8. Hepatitis C is a significant public health problem associated primarily with illicit injection drug use in the United States. 9. No vaccines exist for the prevention of hepatitis C compared to the individual and combined vaccines that are available for the prevention of hepatitis A and B10. The availability of pegylated versions of interferon has allowed for less frequent dosing and better therapeutic response in chronic hepatitis C. However, therapeutic response of patients with chronic hepatitis C to combination pegylated interferon alpha and ribavirin therapy is expected in less than half of treated patients with genotype. Hepatitis is a major cause of morbidity and mortality in the United States. Viral hepatitis refers to the clinically important hepatotrophic viruses responsible for hepatitis A, abbreviated as HAV, hepatitis B, abbreviated as HBV, hepatitis C, abbreviated as HCV, delta hepatitis, and hepatitis E. Hepatitis G virus has also been described, however, its role in clinical illness is still not clear. Viral hepatitis has acute, fulminant, and chronic clinical forms, defined by duration or severity of infection. The clinical, biochemical, immunoserologic, and histologic features of viral hepatitis follow similar patterns regardless of the virus responsible for the patient's illness. Hepatocellular response to injury and the resulting physical signs and symptoms are nonspecific. HAV is primarily responsible for acute hepatitis. It is most often linked to sporadic events of contaminated food in the United States and to international travel, and is usually a self-limited disease. HBV and HCV are primarily responsible for the development of chronic hepatitis, cirrhosis, and hepatocellular carcinoma. Immunomodulatory therapy and direct antiviral agents have been developed for both HBV and HCV. These therapeutic modalities require long courses of therapy and are associated with limited success. This chapter will focus on the pathophysiology, clinical course, and management of these 3 primary causes of viral hepatitis, namely HAV, HBV, and HCV. We will now take a closer look at hepatitis A virus. Hepatitis A virus has been associated with significant morbidity and occasional mortality for centuries as a known cause of acute hepatitis. Despite the availability of an effective vaccine against hepatitis A virus, hepatitis A continues to be one of the most frequently reported vaccine-preventable diseases in the United States. Epidemiologic data in the United States from 1997 estimated that hepatitis A infections were responsible for 255 deaths, approximately 2.5 million days of symptomatic illness, 829,000 working days lost, and costs in the range of $330 to $580 million. Next we will discuss the epidemiology and etiology of hepatitis A virus. Hepatitis A virus causes both epidemics and sporadic infections. Both are related to overcrowded conditions and person-to-person spread or ingestion of contaminated food or water. Hepatitis A virus is transmitted by the fecal-oral route. The incidence of hepatitis A virus correlates directly with poor sanitary conditions and hygienic practices. For international travelers, longer lengths of stay in a country with a high rate of hepatitis A also correlates with increased risk. In the United States, groups at increased risk of hepatitis A virus, in addition to travelers, include men who have sex with men, injecting drug users, and persons working with non-human primates. Hepatitis A virus infection in the United States occurs primarily from person-to-person transmission in community-wide outbreaks, in lower socioeconomic groups, and in sporadic common source outbreaks, outbreaks in which all infected patients contract the infection from a single person or source. Children between the ages of 5 and 14 years are more likely to be involved in community-wide outbreaks, whereas common source outbreaks primarily involve young adults. Both children and young adults can be infected from common source outbreaks at daycare centers. Hepatitis A virus infection in children is often asymptomatic or unrecognized. Therefore, children serve as an important source for transmitting the infection to others. Rarely, hepatitis A virus is transmitted by transfusion of contaminated blood products collected while the donor is viremic with hepatitis A virus. Cases of hepatitis A virus associated with parenteral drug abuse are increasing. Hepatitis A virus are small, non-enveloped, single-stranded ribonucleic acid (RNA) viruses belonging to the hepatovirus genus of the Picornaviridae. 4 genotypes are known to infect humans. Most infections are caused by strains from either genotype 1 or 3, although the genotypes do not appear to confer important biological differences. Next we will discuss the pathophysiology of hepatitis A virus. Hepatitis A virus usually causes a self-limiting disease with a low case fatality rate. The disease is a systemic viral infection of up to, but not exceeding, 6 months in duration, producing inflammatory necrosis of the liver. The natural history of the infection is divided into 3 stages based on viral serologic markers, namely, incubation, acute hepatitis, and convalescence. Incubation begins shortly after parenteral or oral inoculation with the virus. After the virus reaches the circulation, infective virions accumulate in hepatic sinusoids and are internalized by the hepatocytes. Hepatitis A virus replication occurs exclusively in the hepatocytes and gastrointestinal epithelial cells. Viral antigens are found in the hepatocyte cytoplasm during incubation. They are subsequently shed into bile and feces. The largest concentration of viral particles is found in stool specimens during the 1 to 2 weeks preceding clinical illness or elevation of liver enzymes. Infected persons are at peak infectivity at this time. Viral shedding declines as clinical symptoms appear. During the incubation stage, the host is asymptomatic. Acute hepatitis begins with a pre-icteric phase before the onset of jaundice, which parallels initiation of the host immune response and occurs before significant liver cell injury. The pre-icteric phase is frequently associated with nonspecific influenza-like symptoms consisting of anorexia, nausea, fatigue, and malaise. Most patients with acute viral hepatitis develop only a few mild symptoms and minimal hepatocyte damage. This mild disease is called acute anicteric hepatitis. The minimal degree of liver cell damage is reflected by mild elevations of serum bilirubin, gamma globulin, and hepatic transaminase, alanine transaminase, abbreviated as ALT, aspartate transaminase, AST, values to about twice normal. Subsets of patients experience enough hepatocyte destruction to produce significant liver dysfunction characterized by interruption of bilirubin metabolism and flow. This results in clinical jaundice and acute icteric hepatitis. Icteric hepatitis is generally accompanied by fever, right upper quadrant abdominal pain, nausea, vomiting, dark urine, alcoholic that is, light-colored, stools, and worsening of systemic symptoms. Clinical symptoms are accompanied by elevations of the serum bilirubin, gamma globulin, and hepatic transaminases from 4 to 10 times above normal. Most patients with either acute anicteric or icteric hepatitis go through the convalescence stage to complete recovery without developing complications or chronic sequelae. Liver injury is immune-mediated with cytolytic T cells maintaining the primary role in cell destruction. Death of hepatocytes results in viral elimination and eventual resolution of the clinical illness. Viremia begins soon after infection and continues throughout the time liver enzymes are elevated. The host antibody response to hepatitis A virus initially appears as the viral particles begin to disappear from stool. Like most host antibody responses, antibodies of the IgM class appear first and imply recent infection. IgM anti-hepatitis A virus usually is detectable 5 to 10 days before symptoms appear. After 2 to 6 months, the IgM antibodies are replaced with IgG antibodies, which usually persist throughout life and confer immunity to hepatitis A virus. Patients who receive immunoglobulin will have low titers of anti-hepatitis A virus for several weeks after inoculation. Patients who receive hepatitis A vaccine will also have anti-hepatitis A virus. Pause the video and carefully scrutinize Table 41, summarizing clinical presentation of acute hepatitis A before advancing to the next slide. Next we will discuss the clinical presentation of hepatitis A virus infection. Hepatitis or infection usually results in an acute, self-limited disease that rarely leads to fulminant hepatic failure. The clinical features of acute hepatitis A are summarized in Table 41. After an average incubation period of 28 days, with a range of 15 to 50 days, symptomatic individuals will experience an abrupt onset of anorexia, nausea, vomiting, malaise, fever, headache, and right upper quadrant abdominal pain. Patients with underlying liver disease such as chronic hepatitis C infection are more likely to develop fulminant hepatic failure. Clinical symptoms also vary with age. Children younger than 6 years old are usually asymptomatic or have a mild influenza-like illness without clinical jaundice. In contrast, more than 70% of infected adults and older children display the characteristic clinical syndrome of acute hepatitis with elevated hepatic transaminase levels and jaundice. 2. The vast majority of people who become ill with hepatitis A virus completely recover. Hepatitis, a virus infection usually produces a self-limited illness that lasts less than 2 months, although 10% to 15% of patients exhibit a cholestatic illness with predominant elevations of alkaline phosphatase, gamma-glutamyl-transferase, and total bilirubin that continues or is relapsing for up to 6 months. Pruritus is often a major complaint of these patients. A relapse is rarely associated with extrahepatic manifestations such as cryoglobulinemia, arthritis, and vasculitis. No cases of a chronic carrier state or chronic hepatitis have been reported. The gold standard method of diagnosis of an acute hepatitis A virus infection involves detection of serum IgM anti-HAV that becomes positive at the onset of symptoms. The antibody peaks during the early phase of convalescence and remains positive for 4 to 6 months after the onset of the disease. In addition to the presence of antibody, the diagnosis is based on the clinical suspicion, characteristic symptoms, and elevated aminotransferases and bilirubin. Hepatitis, a virus infection, cannot be differentiated from other types of viral hepatitis by clinical or epidemiologic features. Next we will discuss the treatment of hepatitis A virus infection. Let's look at the desired outcome. The ultimate goal in treating acute viral hepatitis is to return the individual to the previous state of health. Intermediate goals while the individual is acutely symptomatic and infectious include decreasing morbidity and acute mortality, normalizing aminotransferases to stop hepatic inflammation, stopping viral replication in the host, and ultimately eradicating the virus. We will now look at a general approach to therapy. Management of acute hepatitis A virus infection is primarily supportive, as the disease is usually self-limited and the majority of patients infected with hepatitis A virus will have full clinical and biochemical recovery within 12 weeks. General measures include a healthy diet, rest, maintaining fluid balance, and avoiding hepatotoxic drugs and alcohol. Special diets are of no benefit. Management includes laboratory tests e.g., international normalized ratio and liver function tests aimed at identifying the group of patients at risk of developing fulminant liver failure. Hospitalization is necessary only for those who have prolonged vomiting, coagulation defects, or fulminant hepatitis. Next we will discuss pharmacologic therapy of hepatitis A virus infection. Pharmacologic agents offer no clear benefit in the treatment of patients infected with hepatitis A virus. Corticosteroids have been used in patients with acute hepatitis A virus when cholestatic hepatitis or fulminant hepatic failure is evident. However, controlled trials have failed to demonstrate any benefit, and in some cases the use of corticosteroids may worsen clinical outcomes. We will now progress to fulminant hepatitis, that is acute liver failure. Liver injury that results in fulminant hepatic necrosis and acute liver failure is relatively rare. When it occurs, death results in days or weeks in nearly 80% of cases. Any potential hepatotoxic agent, e.g., acetaminophen, can be responsible, although viral hepatitis is the most common cause worldwide, especially HBV, that is 1% of patients with acute hepatitis B develop fulminant hepatitis. Fulminant hepatitis caused by hepatitis A virus occasionally occurs. Acute liver failure caused by HCV is rare. Patients with fulminant hepatic necrosis typically develop signs and symptoms of viral hepatitis, and then rapidly develop evidence of hepatic failure. The clinical syndrome is usually a 1 to 3 week course of hepatic failure and encephalopathy, with coma developing within 8 weeks of the onset of acute hepatitis. Hyperexcitability, insomnia, somnolence, irritability, and impaired mental status are evidence of impending hepatic failure. Ominous signs include a rapid decrease in liver size, a rapid decline in aminotransferase levels, prolonged international normalized ratio or prothrombin time, and hypoglycemia. Manifestations of hepatic failure include metabolic encephalopathy, coma, coagulation defects, ascites, and edema. In fulminant liver failure, complications include gastrointestinal hemorrhage, sepsis, cerebral edema, renal failure, lactic acidosis, and disseminated coagulopathy, with death resulting from bleeding, cerebral edema, hypoglycemia, infection, and/or multisystem organ failure. Prompt referral for liver transplantation is the therapy of choice for most patients with fulminant hepatic failure. Transplantation should be considered in all cases in which the patient demonstrates progressive clinical deterioration, encephalopathy, hypoglycemia, metabolic acidosis, renal failure, and coagulation defects. Patients should be transferred at the first sign of altered mental status, because these patients often worsen very rapidly. 1-year survival rates with liver transplantation for fulminant hepatitis are 50% to 80%, as compared to less than 20% with medical management alone. There is no specific medical treatment for fulminant hepatic failure. The goal of medical management is to support organ function in the interim until the liver recovers or a donor organ is available. Management therefore focuses on recognition coupled with prevention and aggressive management of complications. Cerebral edema occurs in 75% to 80% of cases that progress to grade 4 encephalopathy, and is the leading cause of death in these patients. Management includes intracranial pressure monitoring and administration of mannitol 0.3 to 1 gram per kilogram body weight as a 20% solution administered intravenously over 20 minutes when intracranial pressure increases above 20 mm of mercury. Pentobarbital lowers intracranial pressure, but it also can cause severe hypotension, and its use is limited to cases with elevated intracranial pressure that is unresponsive to mannitol and with good cerebral blood flow. Corticosteroids and hyperventilation are of little value in cerebral edema related to acute liver failure. Fresh frozen plasma should be administered for bleeding, histamine 2 blocker therapy should be given to prevent GI bleeding, and aggressive antibiotic therapy should be used for infections. Renal replacement therapy is used for acute renal failure, while fluid replacement with pulmonary artery wedge pressure and cardiac output monitoring, and vasopressors provide circulatory support. Metabolic abnormalities, e.g., hypoglycemia, should be treated with standard metabolic support. For further information on medical therapy, drug dosing, and adverse effects, the reader is referred to the corresponding topics in appropriate chapters of this textbook. New treatment options being evaluated include artificial liver support systems and hepatocyte transplantation. These options are at an early stage of development and further controlled clinical trials are needed to determine safety and efficacy. We will now move on to prevention of hepatitis, a general approach to prevention of hepatitis. Highly effective inactivated vaccines against hepatitis A virus have been available in the United States since 1995. These vaccines can substantially lower the incidence of hepatitis A virus infection, and potentially even eradicate the disease. The most effective means of achieving control of hepatitis A virus infection is to vaccinate all children by incorporating hepatitis A vaccination into routine childhood immunizations. However, a vaccine formulation is currently not available for children younger than 2 years old. Until routine infant vaccination is feasible, the vaccination strategy in the United States includes vaccinating A. children in states, counties, and communities with consistently elevated rates of hepatitis A. B. Persons in groups at increased risk for hepatitis A virus infection, such as international travelers, and C. Persons at risk of adverse outcomes, such as persons with chronic liver disease. Even though effective active and passive immunity agents are available for hepatitis A virus, the importance of avoiding exposure cannot be overemphasized. The most important measures to avoid exposure include good hand washing techniques and good personal hygiene practices. Travelers can minimize risk by avoiding uncooked shellfish, uncooked fruits and vegetables, and by avoiding drinking water and other beverages with ice of unknown purity. If exposure occurs, post-exposure prophylaxis is with immunoglobulin injection. Next we will discuss the use of immunoglobulin to prevent hepatitis A. Immunoglobulin, abbreviated as Ig, provides protection against hepatitis A virus by passive transfer of concentrated antibodies, immunoglobulins, against hepatitis A virus, abbreviated as anti-HAV. Immunoglobulin is effective in modifying the course and preventing the spread of hepatitis A virus in 85% or more of exposures when used within 2 weeks following the exposure. Pregnancy and lactation are not contraindications to receiving immunoglobulin. However, when immunoglobulin is administered to pregnant women or infants, thimerosal-free preparations should be used. Both immunoglobulin given intramuscularly and immunoglobulin for intravenous administration contain anti-HAV, but only the intramuscular formulation is used for prevention of hepatitis A virus infection. International travelers are the major group receiving pre-exposure prophylaxis with immunoglobulin. Immunoglobulin is recommended for susceptible persons traveling to developing countries. A single dose of immunoglobulin of 0.02 ml per kilogram IM, administered in the deltoid or gluteus muscle, is recommended if travel is for less than 3 months. For lengthy stays, 0.06 ml per kilogram IM should be given every 3 to 5 months. Dosing is the same for adults and children. The concentrations of anti-HAV achieved after administration of immunoglobulin, or after active vaccination, are 10 to 100 times lower than those achieved after natural infection and are often below the limits of detection for commercial assays. The availability of an effective hepatitis A vaccine has reduced the use of Ig in travelers. However, immunoglobulin is less expensive than vaccination, and remains an alternative for the traveler who does not need long-term protection. If the interval between the first dose of the hepatitis A vaccine and travel is less than 2 weeks, administration of Ig should be considered to provide passive immunity during the interval before active vaccine-induced immunity develops. In this situation, the lower dose of Ig is used. The post-exposure prophylactic benefit from immunoglobulin is greatest early in the incubation period and is of no benefit more than 2 weeks after exposure. In most situations, serologic screening of contacts for anti-HAV is not recommended before immunoglobulin administration because screening is costly and delays prophylaxis. A single immunoglobulin dose of 0.02 ml per kilogram IM is used for post-exposure prophylaxis. Again, the dose is the same for adults and children. People who have been given 1 dose of hepatitis A vaccine at least 1 month before exposure do not need immunoglobulin. Immunoglobulin should be given to previously unvaccinated people who have had a close personal contact with a person who has hepatitis A. B. All staff and attendees of daycare centers when hepatitis A is documented. C. Common source exposures, other food handlers at locations where a food handler has hepatitis A. Patrons, if the infected food handler handled food and had diarrhea or poor hygienic practices. D. Classroom contacts of an index case patient, and E. Schools, hospitals, and work settings at which close contact occurs with index patients. Serious adverse events with immunoglobulin are rare. Anaphylaxis has been reported in individuals with IgA deficiency who have received repeated doses of immunoglobulin. Hepatitis A vaccine can be given concomitantly with immunoglobulin, however, the antibody titer obtained is lower, but still protective, than when the vaccine is given alone. Immunoglobulin can interfere with the response to measles, mumps, rubella, abbreviated as MMR, and varicella vaccines. Administration of MMR vaccine should be delayed for at least 3 months after administration of immunoglobulin, 5 months for varicella vaccine. Conversely, IG should not be administered within 2 weeks after the administration of MMR, 3 weeks for varicella vaccine, unless the benefits of IG clearly outweigh the benefits of vaccination. If immunoglobulin is administered within 2 weeks after administration of MMR, 3 weeks for varicella vaccine, the person should be revaccinated, but no sooner than 3 months, 5 months for varicella after immunoglobulin. We will now look at vaccines to prevent hepatitis A. Inactivated hepatitis A virus vaccines, Havrix from SmithKline Beecham and Vactor from Merck, both demonstrate protective efficacy in 94% to 100% of vaccinees within 1 month after primary vaccination. When a booster dose is given 6 or more months later, essentially 100% of recipients develop high antibody levels. Both vaccines are indicated for immunization of individuals 2 years of age or older. Groups recommended for pre-exposure protection against hepatitis A virus with hepatitis A vaccine are shown in Table 42. Hepatitis A vaccine is useful in preventing secondary infection in household contacts of primary cases of hepatitis A virus infection. However, no recommendations exist for use of hepatitis A vaccine for post-exposure protection. The 2 vaccine products have different formulations and the dosing differs according to the person's age. Table 43 lists the approved dosing for these vaccines. The primary vaccination is a single dose, with a booster dose 6 to 12 months later for children and adults. Both vaccines are injected intramuscularly into the deltoid muscle. The primary immunization should be given at least 2 weeks, preferably 4 weeks, prior to expected exposure to hepatitis A virus. The vaccine can be given at the same time as many other vaccines: diphtheria, tetanus, live or inactivated polio, oral and injectable typhoid, cholera, Japanese encephalitis, rabies, yellow fever, and hepatitis B, without interfering with the immune responses. If one dose is given with one brand and the other dose given with the other brand, protective antibody levels do not differ. The 2 brands are interchangeable. As with other inactivated vaccines, hepatitis A vaccine can be administered to immunocompromised persons. To date, the vaccines are known to have protective levels of anti-HAV for at least 5 to 8 years. Based on kinetic models of antibody decline, protective anti-hepatitis A virus levels should be present for 20 years to life. The vaccine is safe. Side effects include local reactions at the injection site, soreness, induration, redness, and swelling, and headache. Finally, the recent development of a multivalent combination vaccine against both hepatitis A virus and HBV, marketed as Twinrix, provides a more rapid method of vaccinating individuals at risk for both diseases. The vaccine can be administered on days 0, 7, and 21 to provide 99% and 82% immunity against hepatitis A virus and HBV within 1 month, respectively. Immunity rises to 100% for both hepatitis A virus and HBV within 13 months of the end of the vaccination regimen. Pause the video and carefully scrutinize Table 42. Summarizing groups at increased risk of hepatitis A and recommended for pre-exposure hepatitis A vaccination before advancing to the next slide. Next we will discuss economic considerations in prevention of hepatitis. A vaccination against hepatitis A virus without prior screening is only cost-saving for groups of young adults who are exposed to a relatively high risk of hepatitis A virus infection, for example, in communities with high rates of hepatitis A virus. Prior screening for hepatitis A virus antibodies can only be recommended from a cost-effectiveness point of view at expected levels of natural immunity exceeding 35%, moderately endemic countries, or in older travelers. Passive immunization remains the most cost-effective option for occasional short-duration travel to highly endemic areas. Vaccination is cost-effective for individuals who are likely to spend several or prolonged periods in highly endemic countries. On average, vaccination of the U.S. general public is unlikely to be cost-saving, as the cost per infection prevented can be several thousands of dollars. In contrast, vaccination programs targeted to patients at risk for developing hepatitis may be cost-effective. For example, substitution of HBV vaccination programs in sexually transmitted disease clinics serving 1 million patients with a combined hepatitis A virus HBV vaccine was anticipated to prevent 2,263 occult hepatitis A virus infections and cost $13,397 per quality-adjusted life year, abbreviated as QALY. Gained. Similarly, targeted vaccination of patients with chronic HCV with hepatitis A virus vaccination has been deemed cost-effective. Pause the video and carefully scrutinize Table 43, summarizing the recommended dosing of Havrix and Vactor before advancing to the next slide. Next we will discuss hepatitis B virus. Worldwide, over 400 million people are infected with some form of chronic hepatitis B virus. Hepatitis B virus is a leading cause of chronic hepatitis, cirrhosis, and hepatocellular carcinoma. The economic consequences of infection with hepatitis B virus are staggering. Primary prevention through universal vaccination of neonates and adolescents is likely to have the largest impact on curtailing this disease. Let's now look at the epidemiology of hepatitis B virus infection. Hepatitis B virus infection is a worldwide public health problem. The prevalence of hepatitis B virus infection varies in different geographic areas of the world, with carrier rates ranging from 0.1% to 15%. A review of National Health and Nutrition Examination Survey, abbreviated as NHANES-2, between 1976 and 1980, and NHANES-3, between 1988 and 1994, reported a 5.5% prevalence of hepatitis B virus infection in the United States. Black participants had the highest prevalence, that is 12.8%, compared to whites and Hispanics, that is 3% to 5%. In highly endemic areas, China, Southeast Asia, the Middle East, and parts of Africa and South America, hepatitis B virus spread is predominantly by mother-to-infant perinatal transmission and by child-to-child transmission. In highly endemic areas, high rates of chronic viral carriage and virus-associated primary hepatocellular carcinoma are seen. In parts of the world in which the endemicity of hepatitis B virus is relatively low, that is North America, Australia, Western Europe, and temperate South America, the chronic viral carriage rate is correspondingly low, mother-to-infant transmission is relatively uncommon, and hepatitis B virus transmission occurs either through intimate contact or parenterally. High-risk groups in low-endemic areas include intravenous drug abusers, multi-transfused patients, healthcare providers, male homosexuals, heterosexual partners of HBV-infected people, and heterosexual partners of human immunodeficiency virus (HIV) infected individuals. Transmission of hepatitis B virus in the United States occurs predominantly through contact with infected blood products or body secretions, e.g., saliva, vaginal fluids, and semen. The routine practice of screening blood donors for hepatitis B surface antigen, abbreviated as HBsAg, has essentially eliminated hepatitis B virus as a cause of post-transfusion hepatitis. However, products or concentrates of blood such as clotting factors can remain infective despite prescreening for hepatitis B surface antigen. Excluding cases resulting from clotting factor concentrates, most blood-borne hepatitis B virus transmissions are a consequence of accidental inoculation by healthcare workers or the sharing of needles by intravenous drug abusers via percutaneous exposure. The chief obstacles to eradication of hepatitis B virus include the carrier state and infections in utero, neither of which is preventable. Individuals who acquire hepatitis B virus as children postnatally have a very high rate of becoming chronic hepatitis B surface antigen carriers. A small percentage of these children develop complications such as cirrhosis or hepatocellular carcinoma within 20 years of being infected. Unfortunately, for infants who acquire hepatitis B virus in utero, progression to chronic liver disease occurs in about 90% of cases. Immunization of neonates and adolescents is now the current standard of care in the United States, however, only half of the world's countries have such a policy in place. We will now discuss the etiology of hepatitis B virus. Hepatitis B virus is the smallest known deoxyribonucleic acid (DNA) virus, with roughly 3,200 base pairs in its genome. It is an enveloped, double-stranded DNA virus belonging to the Hepadnaviridae family. This family of viruses replicates in the liver and cause hepatic dysfunction cycles that ultimately lead to chronic hepatitis, cirrhosis, and hepatocellular carcinoma. A small spherical and tubular particle known as hepatitis B surface antigen can be found circulating in the bloodstream of infected patients. The viral core contains a single molecule of partially double-stranded DNA referred to as the hepatitis B virus core antigen, abbreviated as HBcAg. The DNA polymerase viral peptide is also found in the core and is referred to as the hepatitis B virus E antigen, abbreviated as HBeAg. Clearance of hepatitis B virus is highly dependent on expression of hepatitis B virus E antigen, which when expressed on the hepatocellular surface induces a potent immunologic response. A lack of hepatitis B virus E antigen expression in certain precore mutants results in more aggressive hepatic disease which is resistant to interferon alpha, abbreviated as IFN alpha, therapy and a higher probability of graft failure after liver transplantation. In addition, hepatitis B virus has been classified into 7 genotypes, that is, A through G, with geographic variance in distribution of these genotypes, specifically, genotype A, which is predominantly found in North America, compared to genotypes B and C, which are found in Southeast Asia. Hepatitis B virus genotype C has been associated with more active necroinflammation in the liver compared to genotype B. The role of other hepatitis B virus genotypes on the natural history of hepatitis B virus is not well characterized. Next we will discuss the pathophysiology of hepatitis B virus infection. Hepatitis B virus is not directly cytopathic, instead liver injury is immune-related, and T lymphocytes are important for both the host cellular and humoral responses. Recovery from acute hepatitis B virus infection depends on both B cell and T cell responses. B cell dependent antibodies are produced to pre-surface and surface antigens. Cytotoxic T lymphocyte response is mounted against multiple epitopes in the hepatitis B virus envelope, nucleocapsid, and polymerase regions. Cytotoxic T lymphocyte-mediated lysis of infected hepatic cells occurs, resulting in liver injury. Immune clearance of virus is often accompanied by worsening liver disease, known as a flare. An extreme example of this is seen in fulminant hepatitis B, when there is often no evidence of hepatitis B virus replication when the patient presents. The virus has been rapidly and aggressively cleared by the infected individual's immune system. Immune-mediated viral clearance can also occur through non-cytolytic pathways via cytokine release. In contrast, development of chronic hepatitis B virus is hypothesized to be a function of poor cytotoxic T lymphocyte response to viral antigens. Hepatitis B virus is not considered a cytopathic virus. In certain circumstances, however, it can cause direct cytotoxic liver injury. Direct cytopathic liver injury can occur when the viral load is very high, as in the rare fibrosing cholestatic hepatitis. After the HBV enters the vascular compartment, it migrates to the liver, where primary replication occurs. The incubation period of hepatitis B virus is 1 to 6 months, much longer than hepatitis A virus. Hepatitis B virus replication occurs in liver cell nuclei, with hepatitis B surface antigen produced in the cell cytoplasm and expressed on the cell surface. These particles are also found circulating in the plasma of patients with acute hepatitis B virus, the chronic carrier state, and chronic hepatitis B virus infection. In acute hepatitis B virus infection, serologic markers proceed in sequence from the development of hepatitis B surface antigen followed by HbAg 30 to 60 days prior to onset of clinical symptoms, through to the appearance of anti-HBs in late convalescence, as shown in Table 44. Antibody to hepatitis B surface antigen, that is, anti-HBs, is initially detected as the concentration of HBsAg in plasma wanes, but is probably present much earlier than detected by standard serologic assays. The presence of anti-HBs without hepatitis B surface antigen indicates protective immunity. See Table 44. Other antigen markers of hepatitis B virus infection include pre-surface 1 and pre-surface 2 for the envelope, and the functional X protein. These markers are not routinely used clinically. Anti-HBc, the antibody directed against hepatitis B virus core antigen, is first detected shortly after the onset of acute cellular injury. See Table 44. Anti-HBc is initially of the IgM class and signifies acute hepatitis B virus infection. IgG class anti-HBc antibodies become detectable several months following the acute hepatitis B virus infection and persist along with HBs antibody for life. Anti-HBc is detectable in essentially all patients who have been exposed to hepatitis B virus. The presence of plasma anti-HBc IgG antibodies signifies prior infection, but it is not protective. See Table 44. HBeAg is a protein subunit of the viral core detected in plasma immediately prior to or at the onset of hepatocyte injury and correlates with a high degree of infectivity. In contrast, the presence of antigen against HBe, that is anti-HBe, correlates with a very low degree of infectivity and portends complete recovery. Anti-HBe becomes detectable either immediately after the peak of liver injury or in early convalescence, and can persist for years. Hepatitis B virus may also play an indirect role in the malignant transformation of hepatocytes through mechanisms related to expression of viral surface markers with oncogenic potential or through integration of viral DNA into the cell. Pause the video and carefully scrutinize Table 44. Summarizing the interpretation of the laboratory profile in hepatitis B virus (HBV) infection before advancing to the next slide. Next we will discuss the clinical presentation of acute hepatitis B. The clinical course of hepatitis B virus infection and the associated clinical features cannot be differentiated from other types of viral hepatitis based on symptoms. The duration of incubation is highly dependent on age and can vary between 6 and 24 weeks. Infants do not develop any symptoms and children between the ages of 1 and 5 years are asymptomatic in 85% to 95% of the cases. Symptomatic infections vary in severity and include fever, anorexia, nausea, vomiting, jaundice, dark urine, clay-colored or pale stools, and abdominal pain. Extrahepatic manifestations of hepatitis B virus infection rarely occur and may include skin rash, arthralgias, and arthritis. Hepatic failure occurs rarely, with a case fatality rate of 0.4%. 0.30 Acute hepatitis B virus infection is diagnosed by the presence of anti-hepatitis B virus core antigen IgM. See Table 44. There are periods during the course of acute HBV infection when specific serologic markers are absent. The lack of such markers complicates diagnosis. These window periods can be seen in the early incubation phase when hepatitis B surface antigen and hepatitis B virus E antigen are not detectable despite the presence of ongoing viral replication, and early in convalescence when these two antigens are cleared prior to the appearance of anti-HBs antibody. Markers of hepatitis B virus replication, hepatitis B virus DNA and DNA polymerase, are sensitive indicators, and are occasionally obtained when a patient is suspected to be in the serologic window period. Low levels of hepatitis B virus DNA can be detected in peripheral mononuclear cells and livers of patients several years after recovery from acute hepatitis B virus. These data indicate that hepatitis B virus is not eradicated in these patients and can be reactivated when their immune systems are suppressed. We will now discuss chronic hepatitis B. The presence of hepatitis B surface antigen in serum for at least 6 months or the presence of hepatitis B surface antigen and the absence of anti-hepatitis B virus core antigen IgM meets the definition of chronic HBV infection. In addition, the presence of hepatitis B virus DNA greater than 10^5 copies per milliliter and persistent or intermittent elevation in AST or ALT levels meet the diagnostic criteria for hepatitis B virus. Risks associated with development of chronic hepatitis B virus include the presence of renal failure, diabetes mellitus, or HIV. The probability of developing chronic hepatitis B virus is inversely proportional to age. Infants have a 90% risk while adolescents and adults have approximately 10% risk. Patients who develop chronic hepatitis B virus are subsequently predisposed to developing chronic liver disease, cirrhosis, and hepatocellular carcinoma, abbreviated as HCC. The clinical presentation of chronic hepatitis B virus is summarized in Table 45. Progression from chronic hepatitis B virus to hepatocellular carcinoma is also age-dependent, with prospective studies indicating a 25% risk in patients who acquire the disease as infants, compared to a 15% risk if contracted as an adolescent. In addition, very high hepatitis B virus DNA levels, normal ALT, and the presence of hepatitis B virus E antigen characterize chronic hepatitis B virus acquired through perinatal transmission. This immune-tolerant phase can last for 10 to 30 years, allowing for individuals with perinatal acquisition to be infectious in their adulthood and perpetuate vertical transmission of the disease. In contrast, children and adults who acquire chronic hepatitis B virus infection present in the immune clearance phase, which is marked by clearance of hepatitis B virus E antigen, in 70% of cases within 10 years. Most patients who seroconvert remain hepatitis B virus E antigen negative and anti-HBe positive with normal ALT and low hepatitis B virus DNA, and are considered to be in an inactive carrier state. Liver biopsies performed in patients with chronic hepatitis B virus infection are classified as chronic persistent hepatitis, chronic active hepatitis, and cirrhosis. Histologic results do not correlate with symptoms, and often patients are asymptomatic until the development of cirrhosis. Cirrhosis is manifested by interlacing strands of fibrous tissue with nodules of regenerating cells, resulting in a characteristic small and knobby-appearing liver. This form of injury is irreversible and can be exacerbated by heavy alcohol consumption and concomitant infection with HCV or HIV. Hepatic decompensation as a result of cirrhosis includes ascites, jaundice, variceal bleeding, and hepatic encephalopathy. The 5-year risk of decompensation after the development of cirrhosis is estimated to be 20%. Pause the video and carefully scrutinize Table 45. Clinical presentation of chronic hepatitis B before advancing to the next slide. Next we will discuss the treatment of hepatitis B virus infection. We will begin with the desired outcome. No specific therapy is available for the management of acute hepatitis B virus infection. Development of fulminant hepatitis secondary to acute hepatitis B virus is rare and is managed with supportive care. See section on fulminant hepatitis. The long-term complications of chronic hepatitis B virus include development of cirrhosis, liver failure, and hepatocellular carcinoma. The key goal of therapy for chronic hepatitis B virus is to eradicate or permanently suppress hepatitis B virus. The short-term objective is to limit hepatic inflammation and to reduce the risk of fibrosis and/or decompensation. The longitudinal goal is to prevent transaminase flares and the development of long-term complications, as well as to prolong survival. Loss of hepatitis B virus E antigen, either spontaneously or with pharmacologic therapy, is independently associated with improved survival in patients with chronic hepatitis B virus. Thus hepatitis B virus E antigen loss and development of anti-HB Ag is a critical outcome measure in patients with chronic hepatitis B virus. In addition, durability of specific pharmacologic therapy for maintenance of hepatitis B virus E antigen seroconversion is also important. Therapeutic strategies include the use of immunomodulators such as alpha interferons and nucleoside analogues. Prevention of hepatitis B virus resistance to nucleoside analogues during therapy is vital for adequate management of these patients. We will now discuss a general approach to treatment. Acquisition of hepatitis B virus within the first 5 years of life is associated with a higher risk for development of cirrhosis. Consequently, early treatment of infants and children should be attempted, given that clearance of hepatitis B surface antigen rarely occurs spontaneously in this group. Spontaneous clearance of hepatitis B virus E antigen occurs at a rate of approximately 10% per year in older groups. Individuals with long-standing disease with hepatic inflammation are likely to be poor responders to therapy and require the most intensive management. Numerous pharmacologic agents with varying modes of action are in clinical development. 3 agents are currently approved for use in the United States by the Food and Drug Administration and include interferon alpha-2b, abbreviated as IFN alpha-2b, lamivudine, and adafovir dipivoxal. No drug therapy is recommended for patients with normal ALT values because this group responds poorly to therapy. Instead, quarterly to biannual follow-up of these patients for hepatocellular carcinoma surveillance and ALT assessment should be considered. Patients with persistent ALT levels greater than twice the upper limit of normal should be considered for treatment. Patients with rising ALT levels, specifically rising to greater than 5 times the upper limit of normal, are considered to be having an exacerbation. Lamivudine therapy should be used for exacerbations because it has a rapid onset of effect. In contrast, interferon alpha-2b onset of action may not be rapid enough to prevent hepatic decompensation. Therapeutic choice between lamivudine and interferon is more controversial for patients who are HbAg positive with ALT levels 2 to 5 times the upper limit of normal. Notably, the relative risk of relapse after hepatitis B virus E antigen seroconversion with lamivudine therapy is about 4 times higher than with an alpha-interferon-containing regimen. The decision to treat individuals is ultimately a function of disease severity, history of flares, hepatic function, drug cost, side effect profile, and patient choice. The long-term effects of interferon alpha-2b are better known than those of lamivudine. In addition, extending the duration of lamivudine therapy with the intent to improve response risks development of resistant hepatitis B virus mutations. The availability of adafovir dipivoxal is promising as rescue therapy after lamivudine because it is active against both wild-type and select mutants of hepatitis B virus. However, well-controlled comparative trials of lamivudine to adafovir dipivoxal are not available. The role of combination therapy has yielded conflicting results and requires further evaluation. And now we will discuss the non-pharmacologic therapy. About 75% of the 400 million people with chronic hepatitis B virus live in Asia. Herbal medication use is a common therapeutic modality in many parts of the world and has been studied extensively in China. A meta-analysis of over 500 papers, including randomized controlled trials, concluded that existing studies were of poor quality, limiting the definitive interpretation of results. However, the meta-analysis did identify that bufotoxin and chororinone were associated with increased seroconversion of hepatitis B virus E antigen and clearance of hepatitis B virus DNA. Further evaluation of these active components as a possible therapeutic alternative is warranted, but they are not currently being recommended for routine use. And now we will look at pharmacologic therapy. Patients considered for treatment are those who are hepatitis B surface antigen positive for greater than 6 months with persistent elevations in serum aminotransferases, detectable markers of viral replication, that is, hepatitis B virus E antigen and hepatitis B virus DNA in serum, and signs of chronic hepatitis on liver biopsy. Although symptomatic patients are more apt to seek medical attention and to have these irregularities discovered, symptoms alone are not a basis for treatment. To be treated with interferon alpha, patients should not have decompensated liver disease or any specific contraindications to the therapy being considered. Current strategies to eradicate hepatitis B virus include the use of antiviral agents that alter viral replication or immunomodulatory agents that modify the host immune response. Interferon alpha-2b, marketed as Intran A, was approved by the FDA for use in chronic hepatitis B virus in 1992. Interferon alpha-2b monotherapy 5 now is used only in selected subgroups of patients with hepatitis B virus. Lamivudine Epivir-HBV was approved for use in chronic hepatitis B virus in 1998, and has broader indications for use, but questions remain regarding optimal duration of use and management of resistant viruses. Adafovir dipivoxal (Hepcera) was approved for use in chronic hepatitis B virus, including lamivudine-resistant hepatitis B virus, in 2002. Endpoints of therapy for hepatitis B virus include disappearance of hepatitis B virus DNA and elimination of hepatitis B virus E antigen, that is virologic response, resolution of elevated aminotransferases, biochemical response, and improvement of liver histology. Hepatitis B virus E antigen seroconversion, an even stricter marker of viral response, denotes the loss of both hepatitis B virus E antigen and hepatitis B virus DNA and the appearance of anti-HBe. Loss of hepatitis B surface antigen can occur even years after completion of therapy. Next we will look at first-line therapy. The American Association for the Study of Liver Diseases, abbreviated as AASLD, has published its guidelines for the management of chronic hepatitis B virus. In addition, the Asian Pacific Association for the Study of the Liver, abbreviated as APASL, has updated a consensus statement on the management of 5 chronic hepatitis B virus. The choice of first-line therapy between interferon alpha-2b and lamivudine is dependent on the categorization of specific patient populations by hepatitis B virus E antigen positivity and ALT level. As stated earlier, factors such as disease severity, history of flares, hepatic function, drug cost, side effect profile, and patient choice ultimately drive drug selection. In patients with chronic hepatitis B virus who are hepatitis B virus E antigen positive and have intermittent or persistent elevation of ALT, either interferon or lamivudine may be used as first-line therapy. Lamivudine should be selected in patients at risk for decompensation given its rapidity of onset. A meta-analysis of 15 randomized controlled trials demonstrated that 33% of patients had loss of hepatitis B virus E antigen with 12 to 24 weeks of therapy with interferon alpha-2b compared to 12% in controls. Pretreatment ALT levels of greater than 100 international units per liter and low hepatitis B virus DNA levels less than 200 copies per milliliter were predictive of improved response to interferon alpha. Similarly, these parameters predict response to lamivudine therapy. 3 randomized controlled trials evaluating lamivudine for a similar patient population have demonstrated a loss of hepatitis B virus E antigen in up to 32% of patients treated for 52 weeks. Consequently, current guidelines do not specifically favor one agent over the other due to a lack of distinct differences in efficacy. The choice of lamivudine or interferon alpha is a function of assessing the limitation of each agent. Interferon alpha-2b is advantageous because its use follows a defined course of therapy and it lacks susceptibility to resistant hepatitis B virus mutants, but it is limited by its cost and side effect profile. In addition, interferon alpha-2b cannot be used in patients with decompensated cirrhosis. Lamivudine is better tolerated but does not sustain a durable response and may be affected by resistant hepatitis B virus mutants. Specific recommendations from the AASLD and APASL are summarized as follows and apply to both adults and children, as shown in Fig. 41. 1. Patients with hepatitis B virus E antigen positive chronic hepatitis B virus ALT greater than 2 times the upper limit of normal, abbreviated as ULN, or moderate to severe hepatitis on biopsy. Treatment may be initiated with either lamivudine or interferon alpha ALT greater than 2 times the upper limit of normal. Treatment with lamivudine or interferon alpha should be limited to patients with significant necroinflammation on liver biopsy. Patients should have their ALT assessed every 3 to 6 months. 2. Patients with hepatitis B virus E antigen negative chronic hepatitis B virus, only patients with ALT greater than 2 times the upper limit of normal, hepatitis B virus DNA greater than 10 power 5 copies per milliliter, or moderate to severe hepatitis on biopsy should be considered for treatment with lamivudine or interferon alpha. 3. Patients who fail to respond to a course of interferon alpha and have ALT greater than 2 times upper limit of normal, hepatitis B virus DNA greater than 10 power 5 copies per milliliter, or moderate to severe hepatitis on biopsy may be treated with a course of lamivudine. 4. Patients with decompensated cirrhosis, interferon alpha should not be used and lamivudine may be considered in these patients. 5. Patients in an inactive hepatitis B surface antigen carrier state, no treatment is indicated. Pause the video and carefully scrutinize Figure 41, illustrating a treatment algorithm for the management of patients with chronic hepatitis B virus infection before advancing to the next slide. We will now move on to alternative drug treatments. Adafovir dipivoxil is the prodrug of adafovir, a nucleotide analog active against hepatitis B virus. In vitro and preliminary clinical evidence demonstrate that adafovir is effective in suppressing hepatitis B virus replication, including lamivudine-resistant mutants. 2 randomized, double-blind placebo-controlled trials were conducted in both hepatitis B virus E antigen positive and hepatitis B virus E antigen negative patients with approximately 50% of cases with ALT levels greater than 2 times upper limit of normal. Loss of hepatitis B virus E antigen was noted in 24% of patients receiving adafovir dipivoxil 10 mg daily compared to 11% in the placebo group at week. A similar loss was noted with adafovir dipivoxil 30 mg daily. However, the higher dose was associated with an 8% incidence of reversible nephrotoxicity, that is equal to or greater than 0.5 mg per deciliter increase in serum creatinine. Given that hepatitis B virus E antigen loss cannot be assessed in hepatitis B virus E antigen negative patients with chronic hepatitis B virus, other endpoints such as hepatitis B virus DNA reduction, normalization of ALT, and changes in liver biopsy inflammatory scores were assessed. Improvement in histologic liver abnormalities were noted in twice as many adafovir dipivoxil treated patients compared to those on placebo. 0.46 Undetectable hepatitis B virus DNA levels were noted in 51% of patients on adafovir dipivoxil compared to none in the placebo arm. ALT normalization was also significantly higher in the adafovir dipivoxil group. No development of resistance to adafovir was noted in these trials. Comparative trials of adafovir dipivoxil to lamivudine have not been conducted to ascertain the placement of this agent. Famciclovir, an oral prodrug of penciclovir, is an effective agent for suppression of hepatitis B virus, but is associated with a low rate of hepatitis B virus E antigen clearance compared to lamivudine. Its use is limited by the need for thrice-daily administration, cross-resistance with lamivudine, and low efficacy. Combination therapy with lamivudine or thymosin alpha-1 is associated with improved hepatitis B virus E antigen seroconversion compared to famciclovir alone. Thymosin alpha-1 is an immunomodulatory agent that enhances the activity of T helper 1 cells. A meta-analysis of studies evaluating thymosin alpha-1 indicated that it has limited activity during therapy, but induces a virologic response 12 months after the end of therapy. More data are necessary to evaluate the role of thymosin alpha-1. Prednisone administration as a tapering course prior to antiviral therapy has been found to be beneficial in small subset of patients. However, patients with underlying cirrhosis are at an increased risk for fatal exacerbations when prednisone priming is given, and its use is not recommended in these patients. Other antiviral agents that have shown promising results in clinical trials include emtricitabine, entecavir, and clevidine. In addition, therapeutic vaccines against specific hepatitis B virus epitopes and pro-inflammatory cytokines are being evaluated. We will now consider special populations. In contrast to interferon alpha-2b with its significant adverse side effect profile, almost all patients are candidates for lamivudine therapy. Patient groups in which lamivudine has shown benefit include various transplant patients, those with decompensated cirrhosis, and patients with hepatitis B virus mutants with mutations in the pre-core region of the viral genome who present as hepatitis B virus E antigen negative and hepatitis B virus DNA positive. Patients with normal aminotransferase levels should not be treated. Monitoring of this group, with treatment if disease progresses, is more advantageous than treatment, because many of these patients will not have progression of liver disease, while therapy is associated with cost and adverse event risk. Whereas the use of interferon alpha-2b is discouraged in patients with decompensated cirrhosis, an open trial of 35 such patients with lamivudine demonstrated significant benefit in laboratory and clinical markers in the 23 patients who were maintained on therapy for greater than 6 months. Hepatitis B virus DNA was undetectable in all patients after 6 months and adverse effects were minimal. Lamivudine also showed no decrease in its activity in patients who had active replication, but were hepatitis B virus E antigen negative. After a year of treatment, 65% became hepatitis B virus DNA negative and had normal transaminases. Patients co-infected with HIV may not respond as well to interferon alpha-2b because HIV-associated immunosuppression can block the antiviral actions of interferon alpha-2b. These patients can be considered for therapy if the disease is relatively well controlled. Only a small proportion of cases of HBV infection in the United States are in children. The efficacy of interferon alpha-2b in children seems comparable to that in adults, and those with elevated ALT levels at initiation of therapy are more likely to respond. A comparative trial of interferon alpha-2b 5 million units per meter squared versus 10 million units per meter squared 3 times weekly for 6 months showed greater hepatitis B virus E antigen clearance with the higher dose, that is 53% versus 7%. Children tolerate interferon alpha-2b therapy better than adults. Although some schemes of induction therapy dosing of interferon alpha-2b have been successful in patients who had not responded to previous interferon alpha-2b therapy, a course of lamivudine should be tried first before trying increased interferon alpha-2b doses. There are insufficient data to clarify management of pregnant patients, immunosuppressed patients, and patients co-infected with HCV. We will now look at drug class information. Interferon alpha was first demonstrated to have benefits in patients with chronic hepatitis B virus in the early 1970s. Development of recombinant technology and eventual availability of commercial forms of interferon alpha have led to several randomized clinical trials in various countries. For a more detailed review of currently available interferon formulations including their pharmacology and disposition, please refer to the HCV section on interferons. Interferon alpha-2b is currently the only interferon approved by the FDA for management of chronic hepatitis B virus. As compared to a placebo response of 12% to 17%, 33% to 37% of patients respond to interferon alpha-2b therapy by losing hepatitis B virus E antigen and hepatitis B virus DNA. Even though most of these patients will maintain a long-term response, the low overall response rates combined with the adverse effects and need for subcutaneous dosing make interferon alpha-2b a less than ideal agent. Pre-treatment predictors of response to interferon alpha-2b include low viral load, hepatitis B virus DNA. For this subset of chronic hepatitis B virus patients, an interferon alpha-2b regimen is a rational option, although these same parameters predict response for lamivudine, an alternative agent. Resolution of hepatitis B virus viremia with interferon alpha-2b is associated with a transient exacerbation of the hepatitis, marked by a rise in serum ALT levels during the second or third month of therapy. Although interferon alpha-2b may have direct antiviral effects, this flare is related to immunomodulatory effects resulting in an increased host response, as shown in Fig. 42. In patients who respond to interferon, hepatitis B virus DNA levels decrease within days of starting therapy. After 8 to 12 weeks, ALT levels increase, and the patient loses hepatitis B virus DNA and hepatitis B virus E antigen. ALT levels then normalize, and the patient develops anti-HBe. Without the flare, loss of viral replication rarely occurs. Patients infected with pre-core hepatitis B virus mutants that prevent hepatitis B virus E antigen expression, hepatitis B virus E antigen negative and hepatitis B virus DNA positive, are less likely to respond to interferon alpha therapy and have a higher rate of relapse upon discontinuation. About 10% of the responders to interferon alpha therapy also clear hepatitis B surface antigen in the first year, and although biochemical and histologic responses also occur, they are more frequent in the group responding virologically. Long-term follow-up of patients treated with interferon alpha has shown that response is sustained in about 90% of patients at least 5 years after therapy, and that a distinct survival benefit is present in those who have a virologic response. Interferon alpha-2b should be administered by subcutaneous injection as 5 million units daily or 10 million units thrice weekly in adults. In children, thrice-weekly subcutaneous injections of 6 million units per meter squared to a maximum of 10 million units per dose is recommended. Patients with hepatitis B virus who are hepatitis B virus E antigen positive should be treated for 16 weeks, while hepatitis B virus E antigen negative patients should be treated for 12 months. Administration of interferon is associated with significant side effects, which diminish with continued treatment. Flu-like symptoms such as fevers, chills, and myalgias should be expected during the first month of therapy, typically several hours after administration. Consequently, administration of interferon alpha-2b at bedtime along with a nonsteroidal anti-inflammatory agent improves tolerability. Pegylated formulations of interferon, see discussion in HCV section, are likely to be more tolerable but have not been studied sufficiently in patients with hepatitis B virus. Additional adverse events associated with long-term interferon alpha therapy include cytopenia, alopecia, thyroid dysfunction, and depression. Depression is a very common complication of interferon alpha therapy, especially during the last third to fourth month of therapy. A high index for suspicion for the mental well-being of patients should be maintained, as suicides have been linked to interferon alpha therapy. Pause the video and carefully scrutinize Figure 42. Typical sustained response to interferon gamma in a patient with chronic hepatitis B before advancing to the next slide. Next we will discuss lamivudine. Lamivudine, marketed as Epivir HBV, or 3TC, is a nucleoside analog that competitively inhibits viral reverse transcriptase and terminates proviral DNA chain extension. Because it does not affect host response, it suppresses viral replication but does not directly eliminate the virus from the hepatocytes. Its efficacy is also not associated with, or dependent upon, the flare response seen with interferon. Like interferon alpha-2b though, lamivudine demonstrates higher response rates in patients with elevated transaminases, that is ALT greater than 100, and lower viral loads. Two double-blind randomized controlled trials in adults compared lamivudine 100 mg by mouth daily for 52 weeks versus placebo in previously untreated patients. The results are comparable except that one trial in Asia had a higher biochemical response in both treatment and placebo groups. Both trials demonstrated significant histologic, virologic, and biochemical responses with lamivudine. Lamivudine also prevented histologic worsening or the development of hepatic fibrosis. The results of the Asian trial are especially impressive because it was previously thought that this was a difficult population to treat because of acquisition of disease at an early age. Long-term outcomes are not proven, but the results of these trials are encouraging. Of note, the 32% rate of HbAg loss in the American trial is similar to the response demonstrated with interferon alpha-2b. Upon discontinuation of lamivudine, hepatitis B virus DNA tends to rebound, but to levels less than the original baseline. Virologic responses were maintained in about 75% of lamivudine-treated patients 16 weeks post-therapy. Treatment beyond 1 year increases the rate of hepatitis B virus E antigen loss and slows the rate and extent of hepatitis B virus DNA return. However, extending the duration of therapy would be associated with a possible increase in adverse effects, increased cost, and increased development of resistance to lamivudine. But a recent pilot study evaluating a 3-year lamivudine regimen in 16 patients noted histologic improvement despite development of lamivudine-resistant mutants and virologic breakthrough. Mutations in regions of reverse transcriptase, primarily the YMDD locus, confer resistance against lamivudine. These mutations occur after about 6 months of lamivudine therapy, are usually accompanied by increases in ALT and hepatitis B virus DNA, and are more common in patients with elevated baseline viral loads. In the 2 lamivudine trials, the incidence of these mutations was 14% and 32%, respectively, after 1 year of therapy. It is thought that the mutant viruses are relatively less harmful because they are not able to replicate as effectively, but the mutants are replaced by wild-type virus upon treatment discontinuation. Despite the development of resistance with continued lamivudine therapy, the ALT and hepatitis B virus DNA often remain below baseline levels and some patients may still convert from a HbAg-positive state. In the foregoing studies, one reported no association between treatment and transaminase level changes, whereas the other reported post-treatment levels greater than 3 times baseline in 25% of the treatment group, compared to 8% in the placebo group. A different cohort of 55 patients had much a higher mutation rate, 58% after 2 years of lamivudine therapy, with 13 patients, 24%, experiencing an ALT spike over 10 times the normal range, and 3 patients, 5%, demonstrating hepatic decompensation during the flare. Lamivudine has a much less toxic adverse effect profile than interferon alpha-2b, with serious side effects occurring at rates similar to those of placebo. The most commonly reported are fatigue, nausea and vomiting, headache, cough, and diarrhea. It is administered as a tablet or oral suspension at a dose of 100 mg orally once daily. Lamivudine is well absorbed and has renal elimination, requiring dosage adjustment if the creatinine clearance is less than 50 ml per minute. Response to lamivudine is more rapid than that of interferon alpha-2b, with hepatitis B virus DNA levels decreasing by 97% after 2 weeks of therapy, and it has demonstrated success in patient subgroups that typically do not respond to interferons. In summary, lamivudine is more convenient, has fewer adverse effects, and demonstrates at least comparable virologic, histologic, and biochemical activity compared to interferon alpha-2b. The optimal duration of therapy with lamivudine is not known, especially considering that the correct course of action when resistance occurs is still unknown. With little comparative data, one is left to choose between a relatively short course of an injectable agent with demonstrated adverse effects but documented long-term outcomes, versus a well-tolerated oral agent with activity across a greater spectrum of patients, but whose long-term effects and optimal duration of therapy are unknown. We will now discuss adafovir dipivoxel. Adafovir is a nucleotide analog of deoxyadenosine monophosphate that is active against retroviruses like HIV, herpes viruses, and hepadnaviruses. Adafovir dipivoxel 10 mg by mouth once daily for 48 weeks has been approved for use in adult patients with chronic HBV who are either treatment-naive or have lamivudine-resistant HBV. This agent is also active against HIV but requires higher, that is 125 mg daily, doses for treatment. Consequently, the use of adafovir in HBV patients co-infected with HIV may induce antiretroviral resistance. However, in contrast to lamivudine, the long-term use of adafovir has not been associated with the development of resistance in hepatitis B virus. Adafovir is generally well tolerated with primary adverse effects including headache and abdominal pain. Nephrotoxicity is associated with adafovir and appears to be a dose-related effect. The incidence of nephrotoxicity defined as a 0.5 mg per deciliter increase in serum creatinine has not been noted in patients treated with 10 mg for 48 weeks. In contrast, a 120 mg daily dose of adafovir was associated with nephrotoxicity in 35% of patients with 48 weeks of therapy. Next we will discuss pharmacoeconomic considerations. Treatment of chronic hepatitis B virus in patients with favorable predictors of response is cost-effective, especially among younger individuals. The direct cost of management of chronic hepatitis B virus with interferon alpha-2b would be approximately $7,500 and $25,000 for a 16-week and 12-month course, respectively. In contrast, the annual cost of lamivudine and adafovir would be approximately $2,000 and $6,400, respectively. However, acquisition cost alone cannot be used to evaluate the expected value of using each agent. using data from a meta-analysis of 9 trials with 552 chronic hepatitis B virus patients. Interferon alpha-2b treatment would increase life expectancy by 3.1 years and decrease lifetime costs by more than $2,100.64. A more recent comparative evaluation of the cost per additional hepatitis B virus E antigen seroconversion was estimated to be $12,703 with lamivudine compared to $39,922 with interferon alpha-2b. However, this assessment included a decision tree model limited to 1 year of evaluation and so did not take into account the relapse rates post-lamivudine discontinuation. Pharmacoeconomic analyses of the impact of adafovir have not been published. Given that lamivudine resistance emerges in 15% to 30% of persons treated in the first year, it is likely that future regimens may include either early combination regimens of adafovir and lamivudine, or a stepwise approach. Future pharmacoeconomic analyses must compare the cost-effectiveness of interferon alpha-2b to potential combination regimens of adafovir and lamivudine. Let's briefly talk about clinical controversies. Some clinicians believe that adafovir should be used as first-line therapy or at least in combination with lamivudine to prevent development of YMDD mutants. However, others argue that adafovir should be used after the development of breakthrough YMDD mutants during lamivudine therapy. The impact of hepatitis B virus E antigen clearance and seroconversion on the long-term outcome of patients is not clearly defined. Some clinicians would argue that the true impact of therapy may be limited given that hepatocellular carcinoma may develop in patients even after many years of serologic recovery. And now we will move on to evaluation of therapeutic outcomes. Hepatitis B virus E antigen, hepatitis B surface antigen, and hepatitis B virus DNA should all be measured at the start of therapy, at the end of therapy, and 6 months thereafter. Aminotransferases are measured at monthly intervals in conjunction with clinical monitoring for possible decompensation, development of ascites, encephalopathy, and esophageal varices. The monthly monitoring of ALT should detect the presence or absence of a flare, and may also help signal the development of lamivudine resistance. When lamivudine therapy is discontinued, virologic and biochemical monitoring should still occur at 6 months post-therapy. Similar monitoring parameters apply with the use of adafovir, with the added provision of routine renal function assessment. Baseline and ongoing monitoring of interferon alpha toxicity includes complete blood counts with platelets weekly during the first 2 weeks of therapy and monthly thereafter. Thyroid tests should be checked at baseline and every 3 to 6 months during treatment. Patients should be asked about their level of performance, mood changes, ability to concentrate, and symptoms. Next we will discuss prevention of hepatitis B. General approach to prevention. The 2 types of products available for prevention of hepatitis B infection include hepatitis B vaccine provides long-lasting active immunity, and hepatitis B immunoglobulin (HBIG) provides temporary passive immunity. The vaccine is used in pre-exposure prophylaxis. It is also used in post-exposure prophylaxis in combination with hepatitis B immunoglobulin. Vaccination is the most effective method for preventing hepatitis B. Tables 46, 47, 48, and 49. Hepatitis B immunoglobulin and IG to prevent hepatitis B. Hepatitis B immunoglobulin is used only in post-exposure prophylaxis. Post-exposure prophylaxis for HBV is recommended for perinatal exposure, sexual exposure to hepatitis B surface antigen-positive persons, percutaneous or permucosal exposure to hepatitis B surface antigen-positive blood, and exposure of an infant to a caregiver who has acute hepatitis B. See Table 47. Hepatitis B immunoglobulin is given to immunocompromised patients for the same indications and in the same doses as immunocompetent individuals. The recommended dose is 0.06 ml per kilogram administered intramuscularly. Guidelines for use are listed in Tables 46 and 47. Use of IG for prophylaxis of hepatitis B virus infection is only recommended when hepatitis B immunoglobulin is not available. Immunoglobulin contains anti-HBs in titers of 1 to 100 to 1 to 1000, in comparison to the 1 to 100,000 or greater anti-HBs titer found in hepatitis B immunoglobulin. IG and hepatitis B immunoglobulin available in the United States do not transmit hepatitis B virus, HIV, or other viruses. We will now look at vaccines to prevent hepatitis B. The comprehensive vaccination strategy in the United States targets interruption of transmission at all age groups through routine infant immunization, continued vaccination of high-risk older adolescents and adults, e.g., HIV-infected individuals, routine screening of pregnant women for hepatitis B surface antigen, and vaccination of all unvaccinated children ages 0 to 18 years of age. See Tables 48 and 49. Several states have laws mandating hepatitis B immunization prior to entry into kindergarten or middle school. In countries where the risk of hepatitis B is relatively low, such as the United States, determining who to vaccinate prior to exposure depends on the risk of infection in that group and the relative cost of pre-testing versus the cost of vaccination. Everyone in high-risk low-prevalence groups, such as healthcare professionals in training, can be vaccinated without screening. To comply with federal guidelines, employers offer healthcare workers with potential exposure to blood hepatitis B vaccination at no cost. In addition to vaccinating healthcare workers against hepatitis B, other infection control practices are important in preventing transmission of the virus because up to 10% of people do not develop an adequate antibody response to the vaccine. The most important infection control measure is the use of universal precautions. These precautions prevent exposure to blood and blood-derived body fluids via use of a variety of barrier precautions, measures to prevent needle sticks, environmental control measures, and good hand washing techniques. However, if a worker is exposed to material that potentially contains hepatitis B virus, recommendations for percutaneous exposure to hepatitis B virus should be followed. See Table 47. The two recombinant hepatitis B vaccine products available in the United States, marketed as Recombivax HB, Merck, Engerix B, SmithKline Beecham, have comparable immune responses and safety profiles. The vaccines contain 5 to 40 micrograms hepatitis B surface antigen protein per milliliter adsorbed onto aluminum. Neither brand of hepatitis B vaccine contains thimerosal. The recent availability of a combined hepatitis A virus and hepatitis B virus vaccine allows for a more accelerated schedule for immunization. For a more detailed comparison of the potential vaccination schedules, refer to the cited reference. These vaccines are some of the safest available. Side effects of the vaccine are soreness at the injection site, headache, fatigue, irritability, and fever. The number of patients experiencing adverse reactions decreases with each vaccine dose, and adverse reactions are less common in infants and children than in adults. There is no association between Guillain-Barré syndrome and the recombinant vaccine, and the vaccine does not transmit HIV. The hepatitis B vaccine is contraindicated for patients with anaphylaxis to common Baker's yeast. Hepatitis B vaccines are inactivated and can be simultaneously administered with other vaccines. Breastfed infants can be vaccinated with hepatitis B vaccine, as can immunocompromised infants and children. The vaccine can be given to pregnant and lactating women. In the last several years, a small number of claims of serious adverse effects after hepatitis B vaccine administration have occurred. Complaints cover a spectrum of autoimmune and nervous system disorders such as rheumatoid arthritis, optic neuritis, and neurodegenerative disorders similar to multiple sclerosis. Public health officials are confident the vaccine is safe, but because claims of vaccine-induced injury are likely to continue, several epidemiologic studies are underway to evaluate association. Millions of people receive hepatitis B vaccine each year, and some will blame the vaccine for any adverse event that is temporarily related to vaccine administration. Pause the video and carefully scrutinize Table 46. Recommended schedule of immunoprophylaxis to prevent perinatal or sexual transmission of hepatitis B virus infection before advancing to the next slide. Pause the video and carefully scrutinize Table 47. Summarizing recommendations for hepatitis B prophylaxis following percutaneous or permucosal exposure before advancing to the next slide. Pause the video and carefully scrutinize Table 48. Summarizing recommended doses and schedules of currently licensed hepatitis B vaccines before advancing to the next slide. Pause the video and carefully scrutinize Table 4089. Summarizing groups recommended for pre-exposure hepatitis B vaccination before advancing to the next slide. We will now progress to hepatitis C virus. Chronic hepatitis as a consequence of hepatitis C virus has reached epidemic proportions worldwide. The indolent course of hepatitis C virus, which is primarily asymptomatic, has contributed to its transmission. The lack of an in vitro model and its mutability has prevented the development of a prevention strategy through vaccination. Therapeutic agents against hepatitis C virus have provided limited success and have been tempered by their significant adverse event profiles. Next we will discuss the epidemiology of hepatitis C virus. Hepatitis C virus is found worldwide and is transmitted primarily through injecting drug use and contaminated blood products. In the United States, HCV is the most common chronic blood-borne infection. 40% of chronic liver disease is related to hepatitis C virus, and an estimated 8,000 to 10,000 hepatitis C virus-related deaths occur per year. NHANES completed the largest population-based household survey to date from 1988 to 1994. This survey revealed that 3.9 million persons, 1.8% of the general population, were infected with hepatitis C virus and 2.7 million Americans from this group were estimated to have chronic disease. However, this survey did not include data from homeless and incarcerated persons known to have a higher risk for hepatitis C virus infection. Currently, persons in the third and fourth decades of life have the highest prevalence of acute hepatitis C virus, while chronic hepatitis C virus has the highest prevalence rates in persons in the fifth and sixth decades of life. Given that most patients with chronic hepatitis C virus have yet to be diagnosed, a fourfold increase in the number of adults diagnosed with hepatitis C virus is projected between 1990 and 2015. Injecting drug use now accounts for about 60% of new hepatitis C virus cases in the United States. 30% of people with hepatitis C virus report sexual, hemodialysis, household, occupational, or perinatal exposure. No recognized source of exposure can be determined for the remaining 10% of hepatitis C virus infections. Other potential methods of transmitting hepatitis C virus infection include contact with other instruments capable of penetrating the skin or mucous membranes, such as shared contaminated razors, intranasal cocaine, also called snorting, use, tattooing, and body piercing. Snorting cocaine with heroin is associated with nasal ulceration and bleeding thought to promote transmission of hepatitis C virus. Perinatal transmission rates of hepatitis C virus are very low, that is less than 6%, increase with increasing maternal viral load, and are higher when the mother is co-infected with HIV. The virus is inefficiently spread by sexual contact. In studies of long-term spouses of patients with chronic hepatitis C virus and no other risk factors, hepatitis C virus infection prevalence is about 1.5%. Transmission of hepatitis C virus is higher in those with high-risk sexual practices. Homosexual men do not have a higher risk for hepatitis C virus acquisition even when they have a higher number of sexual partners. Next we will look at the etiology. Hepatitis C viruses are enveloped, spherical, single-stranded RNA virus that belongs to the Flaviviridae family. There are 6 known genotypes, numbered 1 through 6, and greater than 50 subtypes, designated by letter 1A, 1B, and so forth, of hepatitis C virus. Genotype 1b often results in the 10 most aggressive form of liver disease, is resistant to interferon therapy, and is associated with a worse prognosis post-transplantation. Frequent errors in RNA transcription coupled with mutations driven by host immunologic pressure lead to generation of extensive genetic heterogeneity. This ability of hepatitis C virus to change rapidly to host pressure permits the ultimate development of chronic infection. Next we will discuss the pathophysiology of hepatitis C virus. After hepatitis C virus gains access to the host, the virus enters hepatocytes. The virus then uncoats and releases the genome to begin replication. The viral genome serves as a template for translation of the polyprotein. The processed non-structural protein forms a complex with the genome and begins synthesis for the negative strand. The negative strand functions as the template for synthesis of the positive strand. The RNA intermediate matures and interacts with the envelope and core proteins to assemble into new virus. Most of the replicative processes are not clearly understood. In comparison to other viruses, hepatitis C virus is more likely to cause clinically chronic silent infection in immunocompetent people. Hepatitis C virus accomplishes this despite active humoral and cellular immune responses that are generally targeted against all viral proteins. In acute hepatitis C virus infection, specific T-cell receptors are activated and hepatitis C virus-specific helper T-cells assist with activation, differentiation, and induction of B-cells, as well as stimulating virus-specific cytotoxic T-cells. These effects are mediated by various immunoregulatory cytokines. CD8+ cytotoxic T-cells recognize hepatitis C virus peptides synthesized in infected cells, with resulting lysis of the infected cells. Both the strength and quality of helper T-cell and cytotoxic T-cell responses appear to differ between patients who recover and those who develop chronic hepatitis C virus infection. Hepatitis C virus elicits only a weak T-cell response in patients who develop chronic infection. Individuals who clear hepatitis C virus have a stronger type 1 T helper response that upregulates cellular immunity. The reasons for this are unclear, but are unrelated to general immune tolerance or immunosuppression. Virus-specific antibodies interfere with viral entry into host cells and opsonize the virus for elimination by macrophages. However, they cannot eliminate the virus from infected cells. In addition, the humoral immune response can select hepatitis C virus variants with sequence changes that allow escape from antibody recognition. Antibodies to one genotype confer no resistance to another genotype. As a consequence of these factors, hepatitis C virus is able to escape immune surveillance and establish persistent infection more readily. These characteristics of hepatitis C virus also contribute to poor interferon response and make it difficult to develop a vaccine. Furthermore, the absence of an in vitro cell culture system has limited studies designed to screen newer antiviral compounds. Hepatitis C virus is found in both serum and in an intracellular reservoir. Whereas the half-life of hepatitis C virus in serum is only hours, hepatitis C virus in the infected cell can have a half-life between 2 and 70 days. Hepatitis C virus production can occur in infected cells at a rate of greater than 3.7 times 10^11 virions per day. Therefore, therapy may have to be targeted to eradication of hepatitis C virus-infected cells or administered for prolonged periods. Next we will discuss the clinical presentation. Acute hepatitis C patients with acute hepatitis C are often asymptomatic, but they may have malaise, anorexia, and jaundice, which occur in up to 25% of cases. The mean incubation period of hepatitis C virus is 50 days and viremia can be detected within 3 weeks of initial exposure. Hepatic transaminase values, specifically serum ALT, can be elevated within 4 to 12 weeks of exposure. Acute hepatitis C can be associated with severe symptoms, but fulminant disease is rare. Co-infection with HIV and a history of chronic alcohol consumption are associated with more severe disease during acute hepatitis C virus infection. An important feature of hepatitis C infection is that up to 70% of cases develop chronic hepatitis. Of note, patients with asymptomatic acute hepatitis C virus infection may be more likely to develop chronic hepatitis C virus. Several diagnostic tests are available to detect acute hepatitis C virus infection through detection of antibodies or viral target amplification. Antibody detection methods include enzyme immunoassay (EIA) and a recombinant immunoblot assay, abbreviated as REBA. Specific antibodies to hepatitis C virus by enzyme immunoassay are positive in only 50% to 70% of patients during the initial onset of symptoms, but 90% of patients have hepatitis C virus antibodies after 3 months. A number of viral antigens are included in the current version of enzyme immunoassay, resulting in a 99% sensitivity and specificity for detection of hepatitis C virus antibodies in immunocompetent patients. Patients with autoimmune disorders may have a false positive enzyme immunoassay and no detectable hepatitis C virus RNA, in which case the recombinant immunoblot assay may be used as a supplemental test to rule out hepatitis C virus. Viral target amplification techniques are used to detect hepatitis C virus RNA either qualitatively or quantitatively. Qualitative tests are more sensitive with a detection limit of up to 100 copies per milliliter and should be reserved to determine spontaneous clearance of acute infection. Spontaneous clearance of hepatitis C virus can occur in 50% of patients within 3 months of the acute onset of symptoms. Next we will discuss chronic hepatitis C. Most patients with hepatitis C virus remain asymptomatic until the development of progressive liver fibrosis leading to cirrhosis, end-stage liver disease, and hepatocellular carcinoma. Current estimates indicate that 10% to 30% of patients with hepatitis C virus infection develop cirrhosis, and 1% to 5% develop hepatocellular carcinoma. If an hepatitis C virus patient is symptomatic, fatigue, malaise, anorexia, and weight loss are common. Many patients have a history of jaundice. On physical examination, hepatomegaly is usually present, but the stigmata of chronic liver disease, that is spider nevi, splenomegaly, palmar erythema, testicular atrophy, and caput medici, are generally absent until late in the disease course. Mild but persistent elevations of the serum aminotransferases, bilirubin, and gamma-globulin levels can be seen. Physical symptoms do not correlate well with the severity of liver injury. The diagnosis of hepatitis C virus is made by detecting anti-hepatitis C virus via enzyme immunoassay, with confirmatory recombinant immunoblot assay testing reserved for low-risk populations to exclude potential false positive enzyme immunoassay results. In chronic hepatitis C, there is frequently little clinical evidence that the disease is progressing. The patient is asymptomatic, yet viral RNA remains positive, and if a liver biopsy is performed it demonstrates ongoing liver injury and progressive histologic changes. To assess chronic hepatitis C virus, liver biopsy is the only reliable indicator of disease progression. Importantly, a liver biopsy contributes information on the possible interplay between steatosis and concurrent alcoholic liver disease toward the progression of chronic hepatitis C to cirrhosis. Serum transaminases are prone to fluctuation and can even normalize, confounding the diagnosis. Unfortunately, the patient can be on an insidious course that progresses to complications after a period of years to decades. It is not uncommon for a patient to present to a physician with cirrhosis or portal hypertension secondary to hepatitis C virus infection that occurred years to decades prior, yet the patient may have had few or no clinical signs or symptoms during the intervening years. Hepatocellular carcinoma may present as a nonspecific right upper quadrant pain in patients with cirrhosis. Specific screening guidelines have not been validated to predict the development of hepatocellular carcinoma. Hepatic ultrasound is more sensitive for the diagnosis of hepatocellular carcinoma compared to serum alpha-fetoprotein concentrations. Diagnostic procedures for the evaluation of hepatocellular carcinoma should be reserved for patients with cirrhosis, as the development of this disease is very rare in non-cirrhotic patients. A variety of rare extrahepatic clinical syndromes have been associated with chronic hepatitis C virus infection. These syndromes include cryoglobulinemia, cutaneous vasculitis, renal disease, neuropathy, lymphoma, and Sjogren's syndrome. Cryoglobulinemia involves the presence of circulating immunoglobulins that reversibly precipitate at equal to or less than 37 C. These cryoglobulins can precipitate in small blood vessels and induce a vasculitis. The cutaneous manifestation typically includes a palpable purpura in the lower extremities, and is diagnosed as a leukocytoclastic vasculitis on biopsy of the lesions. Renal disease typically manifests as nephrotic syndrome with pathology consistent with membranoproliferative glomerulonephritis. Peripheral neuropathy is the most common neurologic symptom in patients with hepatitis C virus. Sensory loss may manifest bilaterally or may affect multiple isolated nerves. Hepatitis C virus-related non-Hodgkin's lymphoma is the most common lymphoproliferative disorder recognized in patients with hepatitis C virus. Interestingly, extranodal involvement in the liver and salivary glands may be 3 to 4 times higher in patients with hepatitis C virus versus non-hepatitis C virus infected patients with non-Hodgkin's lymphoma. Finally, symptoms of Sjogren's syndrome such as xerostomia and xerophthalmia may occur in up to 10% of patients with hepatitis C virus. Hepatitis C virus-associated Sjogren's syndrome appears to affect women more than men. Interferon therapy with ribavirin has been reported to have beneficial effects on these extrahepatic manifestations, with the exception of neuropathy and Sjogren's syndrome. Next we will discuss the treatment of hepatitis C virus infection. We will begin with the desired outcome. The ultimate goal in treating acute hepatitis C virus is to return the individual to the previous state of health, and prevent the development of chronic infection. Intermediate goals, while the individual is acutely symptomatic and infectious, include decreasing morbidity and acute mortality, minimizing the chance that the infected person is infecting others, normalizing aminotransferases, cease hepatic inflammation, stopping viral replication in the host, and ultimately eradicating the virus. The goal of treatment is to prevent the morbidity and mortality associated with end-stage liver disease by eradicating hepatitis C virus. Effective treatment of chronic viral hepatitis should also increase the quality of life and prevent infected patients from serving as reservoirs of infection. Because the complications of chronic hepatitis may take decades to manifest, clinical trials primarily use outcomes of virologic response, clearance of virus, biochemical response, return of transaminases to normal levels, and histologic response as surrogate markers for decreased risk of cirrhosis, hepatocellular carcinoma, or death. Long-term outcome studies show that the response to therapy can be maintained for years and that progression of liver disease can be halted. Even regression of fibrosis, once thought to be irreversible, is possible. Sustained virologic or biochemical response is also associated with a reduced risk of hepatocellular carcinoma. Next we will discuss general approach to treatment. Management of acute hepatitis C virus is primarily supportive. General measures include a healthy diet, rest, maintaining fluid balance, and avoiding hepatotoxic drugs and alcohol. Hospitalization is sometimes required in patients with prolonged vomiting, coagulation defects, or fulminant hepatitis. Upon the diagnosis of chronic viral hepatitis, the patient should be informed about the disease risks and a program of regular monitoring established. Depending upon where in the course of infection the disease is diagnosed, monitoring for progression is important for selection of patients for pharmacologic treatment, because many more patients die with chronic viral hepatitis than from it. The relative benefits of pharmacologic therapy and their attendant adverse effects and risks need to be discussed as well. Next we will discuss non-pharmacologic therapy. Liver transplantation is currently the only definitive therapy for the management of hepatic failure. However, transplants cannot be performed in all patients that require them due to the shortage of cadaveric organs. Consequently, the use of liver support systems can provide specific liver functions until an orthotopic liver transplantation is performed. The molecular adsorbents recycling system is a novel technologic system that uses albumin to remove water-soluble and albumin-bound toxins such as bile acid and bilirubin from the bloodstream. This liver dialysis system improves the maintenance of electrolytes, acid-base and fluid balance, glucose concentrations, and removes ammonia. The system benefits patients with liver failure who have renal complications as well. Prospective trials evaluating the efficacy and cost-effectiveness of the molecular adsorbents recycling system versus standard care are currently being completed. Next we will discuss pharmacologic therapy. Patients seropositive for hepatitis C virus with elevated ALT and inflammation on liver biopsy are candidates for antiviral therapy. A more difficult treatment decision occurs when a patient has elevated ALT, but the histologic changes are mild. In that situation, the patient may be closely monitored and treatment withheld. Because relapse frequently occurs shortly after IFN-alpha monotherapy is stopped, response to hepatitis C virus treatment is broken into three general categories. Response refers to a reduction of hepatitis C virus RNA to undetectable levels and normalization of ALT during treatment and 6 months after completion of therapy. Non-response refers to a scenario where hepatitis C virus RNA remains detectable or ALT fails to normalize during the course of therapy. Relapse refers to a scenario where hepatitis C virus RNA becomes undetectable and ALT normalizes during treatment, but either ALT or hepatitis C virus RNA re-emerge in the 6 months after therapy. Occasionally, different time points are used to record results as end-of-therapy responses or as sustained virologic response, abbreviated as SVR, at least 6 months after therapy. Sustained virologic response has been acknowledged as the best predictor of a long-term clinical outcome. The National Institutes of Health Consensus Panel published recommendations on the management of hepatitis C virus infection in 2003. Combination therapy has been recognized to be better than monotherapy. In addition, many of the early treatment recommendations have been supplanted by comparative data showing the superiority of pegylated interferon therapy in conjunction with ribavirin. The duration of therapy has now become a function of the specific genotype of hepatitis C virus. A review of the published guidelines and the data supporting these recommendations are presented below. We will now discuss the first-line therapy. The pharmacologic management of acute hepatitis C virus is confounded by limitations in the ability to recognize the infection in mainly asymptomatic patients. Trials evaluating the role of interferon therapy included small sample sizes and used heterogeneous endpoints to evaluate outcomes. Despite these limitations, sustained virologic responses in the range of 83% to 100% have been reported with interferon alpha monotherapy in small uncontrolled trials, suggesting the potential advantages of early therapy. However, the timing, type of regimen, and duration of therapy remain undefined. The management of treatment-naive patients with chronic hepatitis C virus is better defined with recent large randomized controlled trials comparing pegylated interferon plus ribavirin to interferon and ribavirin. Interferon is an immunomodulatory protein that works by binding to specific cell surface receptors that stimulate a host of gene transcriptions to prevent de novo infection in hepatocytes. In addition, interferon alpha is thought to reduce hepatitis C virus heterogeneity while stimulating pro-inflammatory systems to help increase viral eradication. Interferon is commercially available as interferon alpha-2A, interferon alpha-2B, pegylated versions of both products, and as interferon alpha-1. The process of pegylation includes the attachment of inert polyethylene glycol to protein 10, resulting in an increase in net molecular size. This decreases the rate of subcutaneous absorption, decreases systemic clearance, increases exposure, and thus allows less frequent administration of the product. Ribavirin is a guanosine nucleotide analog that inhibits viral replication and works synergistically with interferon alpha. The pegylated forms of interferon alpha-2A and interferon alpha-2B have distinct pharmacokinetic profiles. Both forms have been compared to monotherapy, in combination with ribavirin, and against interferon alpha-2B plus ribavirin. However, pegylated interferon alpha-2A has not been directly studied against pegylated interferon alpha-2B. These trials excluded patients with comorbid conditions such as HIV infection, autoimmune disorders, pre-existing psychiatric illness, cytopathies, and patients with decompensated liver disease. In general, both pegylated interferon alpha products plus ribavirin were more effective than interferon alpha plus ribavirin or pegylated interferon alpha alone. Patients with hepatitis C virus genotype 1 demonstrated a sustained virologic response in about 40% of cases, while close to 80% of patients with hepatitis C virus genotypes 2 and 3 had a sustained virologic response. In addition, patients with lower baseline hepatitis C virus RNA levels, less fibrosis on liver biopsy, and a lower body surface area or weight were more likely to have a successful clinical outcome. A 24-week course of pegylated interferon alpha plus ribavirin results in similar outcomes to a 48-week course for patients with hepatitis C virus genotypes 2 and 3. However, a 48-week course of therapy results in a higher response rate than 24 weeks of therapy in patients with hepatitis C virus genotype 1. In addition, 800 mg of ribavirin daily is sufficient for management of patients with genotypes 2 and 3, but a higher dose of 1000 to 1200 mg daily is required for patients with hepatitis C virus genotype 1. We will now look at alternative drug treatments. Current therapeutic options for chronic hepatitis C are limited to ribavirin, interferon alpha, interferon alpha-1, and pegylated interferon alpha. As stated, monotherapy is inferior in attaining sustained virologic response compared to combination therapy. However, combination therapy with ribavirin may be limited by its contraindication for men whose female partners are pregnant, patients with hemoglobinopathies like sickle cell anemia, or known hypersensitivity to this agent. Consequently, monotherapy with pegylated interferon alpha may be considered. This is especially true in patients with hepatitis C virus genotypes 2 and 3, in whom sustained virologic response was achieved in 45% of patients managed with pegylated interferon alpha 2A for 48 weeks. However, the same regimen was associated with an sustained virologic response in only 21% of patients with hepatitis C virus genotype 1. Ribavirin monotherapy using doses of 600 to 1200 mg daily has demonstrated a reduction in necroinflammation. However, patients treated with such a regimen do not achieve an undetectable hepatitis C virus RNA level, and these levels usually rebound to baseline upon completion of therapy. The preclinical evaluation of new antivirals is hindered by a lack of animal models of hepatitis C virus infection. Development of novel interferons and delivery systems, nucleoside analogues with reduced hemolytic potential compared with ribavirin, and inosine 5' monophosphate dehydrogenase inhibitors are being studied as adjunctive therapy to interferon alpha-based regimens. In addition, compounds that inhibit specific hepatitis C virus enzymes like serine proteases, RNA polymerase, and helicase are being evaluated. Prevention of disease progression through the use of antifibrotic agents in patients in whom hepatitis C virus RNA cannot be eradicated is in development. The safety and efficacy of these newer therapies are currently being investigated, and it is likely that these treatment modalities will not be available for at least 3 to 5 years. Herbal medications for the management of hepatitis C virus were recently systematically reviewed, but none of the 14 tested agents demonstrated benefit. We will now discuss special populations. The strict inclusion and exclusion criteria in most studies to date would exclude more than half of all hepatitis C virus-infected patients. Patients with mild liver disease and normal ALT levels are less likely to progress to cirrhosis. Consequently, the role of hepatitis C virus therapy remains controversial. Some experts believe documentation of disease progression through liver biopsies should serve as the impetus for therapy. However, decisions to treat in such populations should be driven by the patient's desire to eradicate hepatitis C virus or their unwillingness to undergo sequential liver biopsies to assess progression. Children and adolescents with chronic hepatitis C virus are likely to be asymptomatic. Pegylated interferon alpha has not been studied in children, and most studies evaluating interferon alpha have been uncontrolled with small sample sizes. These studies have demonstrated a better response in children compared to adults receiving interferon alpha monotherapy, with sustained virologic response rates of 26% with hepatitis C virus genotype 1 and 70% with genotypes 2 and 3. Active illicit injection drug use should not be used to exclude patients from receiving hepatitis C virus therapy and should be assessed on an individual basis. This is critically important given that this group of patients represents the majority of new cases of hepatitis C virus in the United States, and treatment may reduce potential transmission. However, data are limited when evaluating the role of hepatitis C virus therapy in patients with active illicit drug use who are not in a drug treatment program. Use of substance abuse programs such as methadone treatment centers should be encouraged to help reduce risky behaviors. Co-infection with HIV is common in patients with hepatitis C virus given the shared risk factors for transmission. Patients co-infected with these viruses have a more accelerated progression of their hepatitis C virus disease. Most trials to date have excluded patients with HIV or limited them to patients with stable HIV infection. Combination therapy using ribavirin is considered to be superior, however, enhancement of antiretroviral adverse events such as lactic acidosis limits therapy. Concurrent use of ribavirin therapy with didanosine, stivadine, or zidovudine is relatively contraindicated. Obesity has been recognized as a poor prognostic variable for outcomes associated with therapy for chronic hepatitis C virus. Patients with a body mass index of greater than 30 kg per meter squared had a 77% lower chance of response to therapy compared to overweight and normal weight patients. The exact mechanism of this interaction between weight and effect is not known. However, the natural progression of disease may be faster in obese patients and may be related to non-alcoholic steatohepatitis. We will now discuss drug class information. Let's begin with interferons. 3 FDA-approved interferon alpha preparations are currently available in the United States and include interferon alpha 2A, marketed as Rofron A, interferon alpha 2B, marketed as Intron A, and interferon alphacan 1, marketed as Infergan. Interferon alpha-2A and interferon alpha-2B are naturally occurring cytokines that have been manufactured using human recombinant techniques in Escherichia coli. In contrast, interferon alphacan 1 is a non-naturally occurring type 1 interferon also produced using human recombinant techniques, but it has a tenfold higher affinity for cell surface receptors. Despite this theoretical higher activity, interferon alphacan 1 has not been found to be superior to interferon alpha-2b. The mechanism of action of these interferons includes activation of tyrosine kinases that upregulate production of several gene products like 2', 5' oligodenylate synthetase, beta-2 microglobulin, neopterin, and p68 kinases. These gene products are responsible for the immunomodulatory, antiviral, and antiproliferative properties of these agents. All of these products have to be administered subcutaneously 3 times a week. The dosage of 3 to 5 million units of interferon alpha-2A and interferon alpha-2B corresponds to 9 to 15 microgram doses of interferon alphacan 1. The expected rate of sustained virologic response of these products is less than 20% when monotherapy is employed for 24 weeks. Flu-like symptoms such as headache, fatigue, and chills occur in more than two-thirds of patients. Psychiatric adverse events such as nervousness and depression and hematologic toxicities such as neutropenia occur in almost a third of patients. We will now move on to pegylated interferons. Peginterferon alpha-2A, marketed as Pegases, and peginterferon alpha-2B, marketed as Pegintran, are FDA approved for use as monotherapy and in combination with ribavirin for the treatment of chronic hepatitis C virus in patients with compensated liver disease who are interferon treatment naive. Their mechanism of action is similar to that of interferon alpha, but they offer the advantage of higher and sustained concentrations compared to their non-pegylated versions. The size and branching of the polyethylene glycol structure affects tissue distribution and elimination of the parent compound. The polyethylene glycol moiety with peginterferon alpha-2A is approximately twice the size of that of peginterferon alpha-2B. Consequently, the elimination half-life of peginterferon alpha-2A and peginterferon alpha-2B are 80 and 40 hours, respectively. This extension in half-life is in stark contrast to the non-pegylated interferons, which have a half-life of approximately 5 hours. Peginterferon alpha-2A should be administered as a 180 microgram dose subcutaneously once weekly for 48 weeks. In contrast, peginterferon alpha-2B follows a weight-based dosing strategy of 1.5 micrograms per kilogram subcutaneously for 1 year. Other pharmaceutical differences include a requirement for reconstitution of lyophilized peginterferon alpha-2B prior to administration, and a requirement for refrigeration for storage of peginterferon alpha-2A. In addition, peginterferon alpha-2A contains benzyl alcohol and so its use is contraindicated in neonates and infants. The adverse event profile of both agents is comparable to their respective non-pegylated versions. A summary of the incidence of specific adverse events is displayed in Table 4010. Interferons can significantly decrease the clearance of theophylline, resulting in an increased area under the plasma concentration versus time curve. Caution should be used when alpha interferons are initiated in patients on theophylline, as they are likely to require dosage reductions based on therapeutic drug monitoring. Next we will discuss ribavirin. Ribavirin is a synthetic nucleoside antagonist that is administered orally in combination with alpha interferons. Ribavirin has limited utility as monotherapy and should be administered twice daily with food when used in combination with alpha interferons. Ribavirin is currently available in two 200 mg oral formulations, as a capsule marketed as Ribitol, and as a tablet marketed as Copigas. When ribavirin is used with peginterferon alpha-2A for patients with hepatitis C virus genotype 1, it is dosed as 400 mg orally every morning and 600 mg orally every evening in patients up to 75 kg, and 600 mg orally twice daily for patients weighing more than 75 kg. For patients with genotypes 2 and 3, ribavirin is administered 400 mg orally twice daily when administered with peginterferon alpha-2B or peginterferon alpha-2A. Hemolytic anemia is a common complication of ribavirin therapy. Dosage reductions of ribavirin are recommended for changes in hemoglobin values when used in combination with peginterferon alpha-2A. In general, the combination of ribavirin with alpha interferons is associated with numerous adverse events to multiple organ systems, and these should be discussed with patients prior to initiation of therapy. Pause the video and carefully scrutinize Table 4010 summarizing the side effects of interferon alpha before advancing to the next slide. Next we will discuss pharmacoeconomic considerations. 10 to 30% of patients progress to cirrhosis after 30 years. Most individuals with chronic hepatitis C virus in the United States are between the ages of 30 and 49 years and have yet to manifest sequelae of the disease. As a result, the impact of hepatitis C virus on future health care costs is anticipated to be high. Unfortunately, clinical decisions to treat individual patients are confounded by the inconsistent progression and a lack of ability to predict clinical deterioration. Therapy with pegylated interferons and ribavirin can be very expensive and associated with serious adverse events. Consequently, assessing the cost, benefits, and cost-effectiveness of the various therapies is vital. The cost of medications based on average wholesale prices with the use of a pegylated interferon plus ribavirin is approximately $30,000 for a 48-week course of therapy. The cost of using non-pegylated interferon plus ribavirin is approximately $15,000 to $20,000. Assuming conservatively that 10% of all chronic hepatitis C patients, 2.7 million, were eligible for therapy in the United States, with 70% of patients having hepatitis C virus genotype 1, the estimated cost for the pharmaceuticals alone would be approximately $4 billion. However, the cost of not treating hepatitis C virus could lead to future costs associated with hospitalizations related to ascites, cirrhosis, variceal hemorrhage, hepatocellular carcinoma, and liver transplantation. A recent pharmacoeconomic analysis to examine the clinical benefits and cost-effectiveness of newer treatments for chronic hepatitis C virus infection evaluated the incremental cost-effectiveness of using peginterferon alpha-2b plus ribavirin compared to interferon alpha-2b plus ribavirin, and monotherapy regimens of both interferons. The incremental cost per quality-adjusted life year, abbreviated as QALY, saved for combination therapy with peginterferon alpha-2b compared to standard therapy was $36,000 and $55,000 for men and women with hepatitis C virus genotype 1, respectively. The quality-adjusted life year is defined as a patient's desire for a year of life at a diminished state of health compared with life at an optimal state of health. The use of the quality-adjusted life year as a measure helps create a uniform set of values that can be applied to cost-effectiveness data from heterogeneous patient groups. Interpretation of data defining cost per quality-adjusted life year is further hampered by a lack of a standard benchmark to define when a therapeutic regimen should or should not be used. Historically, a cost-effectiveness threshold of equal to or less than $50,000 has been used to define a cost-effective regimen, but this remains controversial when applied clinically. The quality-adjusted life year gains ranged from 0.6 months with interferon alpha-2b monotherapy to 6 months with combination peginterferon alpha-2b and ribavirin therapy in men. The key points of contention when evaluating any pharmacoeconomic analysis are the basic underlying assumptions. A lack of clear understanding of the natural course of chronic hepatitis C virus, including the probability of progression, impairs such studies. For the time being, patient selection on the basis of predictors of response coupled with informed patient decision-making regarding benefits and risks is appropriate. We will now look at clinical controversies. Clinicians argue that a non-invasive dynamic measure of hepatic fibrosis is necessary given that the probability of progression of chronic hepatitis C virus is unclear. Others argue that the development of such tests will still not predict when to initiate therapy. The role of long-term continuous therapy with peginterferon alone or in combination with ribavirin is unknown. Some clinicians believe that long-term combination therapy may improve clinical outcomes in select non-responders. We will now discuss the evaluation of therapeutic outcomes. To carry out the plans outlined above requires that viral genotyping be performed at baseline, with a viral load being assessed if the patient has hepatitis C virus genotype 1. Before treatment, all patients should have a viral genotype performed, have thyroid function assessed, and women should have a negative pregnancy test. Liver biopsy is a useful test to evaluate the stage of fibrosis and may aid with the decision of when to initiate or defer therapy. The value of a pre-treatment liver biopsy in patients with hepatitis C virus genotypes 2 and 3 is limited given that antiviral therapy may lead to a favorable response in up to 80% of patients. During treatment, a complete blood count with platelets should be performed weekly for the first 4 weeks and monthly thereafter. Thyroid tests should be checked every 3 to 6 months during treatment and 6 months after. Hepatitis C virus RNA should be evaluated at baseline and 12 weeks of combination therapy, and additionally depending on the intended duration. This is because early virologic response, defined as a minimum 2 log 10 reduction in the viral load in the first 12 weeks of therapy, is predictive of sustained virologic response in patients with hepatitis C virus genotype 1. Consequently, patients without an early virologic response should have their treatment discontinued to reduce cost and prevent unnecessary adverse events. Aminotransferase and qualitative hepatitis C virus RNA should be performed at the end of therapy and 6 and 18 months after the cessation of therapy. Follow-up biopsy is not indicated. In patients with established or suspected cirrhosis, screening for hepatocellular carcinoma with abdominal ultrasound and serum alpha-fetoprotein is recommended. However, neither the time frame nor cost-effectiveness of such screening has been defined. For patients not started on therapy because of mild histologic disease or normal ALT, liver biopsy should be repeated in 4 to 5 years and ALT at 6-month intervals, respectively. The side effects of alpha interferons occur frequently enough that the patient should be informed about them before treatment begins. See Table 4010. Many side effects are dose-related. The most common and predictable effects are influenza-like and can be counteracted by premedication with a single dose of acetaminophen around the time of injection. Severity decreases with subsequent injections and usually abates in 1 to 2 weeks. Later common adverse effects are fatigue, malaise, and cognitive changes. Because alpha interferon therapy can exacerbate autoimmune disorders, it is important to exclude autoimmune diagnoses before initiating therapy. Thrombocytopenia and granulocytopenia are more common in patients with cirrhosis and hypersplenism. The psychiatric complications are especially severe in those with severe liver disease, occur in up to 20% of patients, and are the most common dose-limiting side effects. Therapy should be discontinued if serious complications occur. The dose of alpha interferon must be reduced in 10% to 40% of patients. Treatment must be discontinued because of adverse effects in 5% to 10% of patients. For many patients, reassurance that the side effects are therapy-related, not severe, and will disappear when therapy is stopped is sufficient. It is always important to reassure both patient and family, especially when psychiatric side effects are evident. These points are critical given that patient adherence is crucial to the ultimate success of hepatitis C virus treatment. Ongoing monitoring of alpha interferon toxicity includes weekly complete blood counts during the first 2 weeks of therapy and monthly thereafter. Patients should be asked about level of performance, mood changes, ability to concentrate, and symptoms. The dose of alpha interferon should be decreased by 50% if any of the following develop: fatigue that interferes with the daily routine, serious mood changes, daily nausea with occasional vomiting, granular cytopenia that is less than 500 per millimeter cubed, or thrombocytopenia that is less than 30,000 per millimeter cubed occurs. Lastly, we will discuss the prevention of hepatitis C virus infection. No vaccine for hepatitis C is available. Vaccine development for hepatitis C virus is difficult because of the extensive genomic variability of the virus, viral mutants, and the lack of efficacy of serum antibodies. Current recommendations for prevention of hepatitis C virus include universal precautions for the prevention of blood-borne infections, and anti-hepatitis C virus screening of blood, organ, and tissue donors. Screening of blood donors has virtually eliminated hepatitis C virus transmission through blood and blood products. Programs that focus on reducing HIV transmission are also likely to decrease transmission of hepatitis C virus in high-risk groups. No clear policy for counseling women of childbearing age exists. Benefit associated with identification of hepatitis C virus infections in healthcare workers is limited. However, the CDC, in collaboration with the Hospital Infection Control Practices Advisory Committee, recommends that healthcare institutions consider implementing policies and procedures for follow-up for HCV infection after percutaneous or permucosal exposures to blood. 69 Follow-up should include testing the source for anti-hepatitis C virus, baseline and 6-month follow-up testing for anti-hepatitis C virus and AST for the person exposed to an anti-hepatitis C virus positive source, confirmation by supplemental anti-hepatitis C virus testing of all anti-hepatitis C virus reactive results, and education of healthcare workers about blood-borne infections. Post-exposure prophylaxis with immunoglobulin or interferon is not recommended. There are no specific recommendations for hepatitis C virus immune prophylaxis for exposed individuals. Prophylaxis with immunoglobulin after needle stick exposure to hepatitis C is not recommended. Thank you.